Right. Good afternoon, everybody. Very nice to see you all. For those that don't know me, I'm George Wharton. I'm a senior lecturer in practice here in the Department of Health Policy. I'm delighted to be chairing this event, and in particular to be welcoming our speaker, a good colleague of mine, Dr. Philip Hayward, who's a health economist and physician who currently leads the programme of work on health system resilience at the OECD. This involves both horizontal work within the OECD, focusing on the multifaceted nature of resilience, and external work with the European Commission and the European Observatory on Health Systems and Policies. Phil was previously a senior lecturer at the University of Technology in Sydney and an independent advisor to the New Zealand, Singaporean and Australian health departments. He's also practiced medicine as an emergency doctor in the Asia Pacific region for over a decade, including in remote and Indigenous communities. So very esteemed speaker. And Phil's going to be speaking on a topic which is very close to my heart, and a topic in which our work has occasionally kind of interceded. The topic of his talk is Beyond Buzzwords, Practical Approaches to Harnessing Health Systems Resilience. So Philip, thank you very much for joining us today. We're delighted to have you with us, and the floor is yours.
Thanks, George. Thanks for the kind words. And it's a delight to present to this audience at the moment. I'm just going to share my screen and then do the classic thing of pausing to check that everyone can see the presentation and that it's in presentation mode. Perfect. So basically, Hugh asked me to talk to the group here about our recent report into health system resilience and why we did it and some of the challenges that we had along the way. One of the things I should say at the very beginning is, as with any product from the OECD, we're grateful for the involvement of many countries and country experts in it. But having said that, the report reflects the recommendations of the OECD authors, and my presentation here reflects my views, not the views of any member country. I'm rapidly going to touch upon four sets of issues, and then it would be great if we could pick up some of these in the Q&A afterwards. And so it's going to be a very quick tour of resilience, but basically the four issues that we were going to talk about is what we're trying to do with this report, how we conceptualize and operationalize resilience as a concept, the main findings of the report, and perhaps the most important issue is what are we going to do in the near future? As with any report, and anyone who's tried to predict the future knows this, that looking back on it, even with the distance of 3 months, there's decisions that we would have made slightly differently if we'd known exactly what was going to happen in 2023. And also Hugh asked me to discuss the issues for resilience around low middle income countries. And I'm going to be a little self-critical in a couple of places, and I expect some of the questions will be a little bit more critical in a couple of the other places. So basically, what was the objective of the report? What were we trying to do? Basically, there was a concern that a lack of resilience underlays some of the outcomes associated with the pandemic, and specifically some of the poor outcomes. And what we wanted to do was use the lens of the pandemic to identify key weaknesses and thus remedial policy options for improving resilience. What we weren't trying to do is a retrospective of the pandemic, but rather we were trying to use the lessons to look forward, to apply solutions to the next problems. So we're focused on determining a set of policies that will improve outcomes in the future, and not just for pandemics, but essentially for all large-scale emergencies and some of the stresses that we all know involve the health system or revolve around the health system. And so one of the things that we decided to do fairly early on was augment a health system perspective with important interconnected systems. And so we chose back in 2021, we chose aged care, investment, trade, and governance as the important interconnected systems. In retrospect, in 2023, I wish we'd pointed to education as another one of the interconnected systems that we'd included. And looking back on it, it was an important miss. So how do we think about resilience? And for this audience, how do we distinguish between resilience and health system performance? And I like to think of it in three different ways. So the main areas of difference is that, as we've touched on, we identify connections well beyond the health system. The second is that we try and look at it in a dynamic way. So not a static picture, but a dynamic picture, including the shock. And then we recognize the potential for feedback and the inevitability of shocks occurring. And all these differences feature in the identification of the key policy areas. Basically, we think that societies need to adapt their health systems to respond to risks beyond the pandemic. And these challenges include issues like AMR and climate change, and as we're seeing in 2023, the polio crisis. Now, how we're conceptualizing resilience from the dynamic components is shown in this slide. Basically, before a shock occurs, we're on the left-hand side of the slide, that we're preparing for a shock, we're going about our usual business, and the health system has some performance. Then when a sufficiently large shock occurs, the performance of the health system suffers as a result of that shock. It's disrupted, and it has to absorb the situation. Then over time, the health system recovers this lost function, learns from the experience, and adapts, hopefully, to be both better performing and more resilient in the future. A key issue here is that we're actually trying to do different things at different times during each of these stages, requiring different activities, different information, and potentially different organizational structures. And so if just looking back on the pandemic, you can think about that. At the very beginning of the pandemic, the issue was making sure we had enough surge capacity and critical care. A little later on, when we started getting vaccinations, it was about immunizing both the vulnerable and the general population. And then a little bit later on from that, it's about trying to catch up on the disrupted and delayed care that occurred. Another incredibly important issue is that decisions made at one point can affect others. And so if we just go through that sequence that I just made out, decisions to delay care so that we can increase the amount of critical care access that there is, means that there's disrupted care later on. So a catch-up that is required later on. And the third thing, and this one I can't emphasize enough, we assume that you cannot avoid all problems. Eventually, the health system will be subject to a disruption, and you may not know exactly which one it is. So the policy dilemma is to make the red as small as possible and the green as large as possible, while preserving a high degree of performance. As you can imagine, you could actually make your system very resilient by not doing much and having a lot just sitting around waiting for an emergency, but you want to have good performance and resilience. Now, previous work in resilience has suggested that the concentration of people's efforts and thinking about this really apply in the first two stages, so the prepare and the absorb, and less on recover and adapt. Now, the report makes recommendations in specific areas, basically drawing on the expertise of the whole OECD. But I just want to focus on the 6 key policy areas that we identified. Now, 3, following the structure that we had discussed before, 3 of these are well within the health system: improving health prior to a shock, ensuring a sufficient and skilled workforce, and better data. And then 3 are beyond the boundary of the health system proper. So further international collaboration. Now, we've emphasized investment in this, but this audience might want to disagree about whether that's the most important one. Improve supply chain resilience and ensuring governance and trust across societies. And basically, why did we pick these 6 areas? Why did we think they are likely to produce benefits? And will they actually make a health system more resilient, is the rest of the talk. And so let's start going through the 6 areas one by one and talking about why we've chosen it from a resilience point of view. So the first is the need to promote healthier populations prior to a crisis beginning. A relatively low health system expenditure on cost-effective health promotion, population health is a focus in the report, and I think it's repeated in every single chapter. But it's larger than that. It involves universal health coverage, primary care, integrated care, and the socioeconomic determinants of health. As everyone knows in the pandemic, and this slide is yet another demonstration, mortality and other outcomes, including long COVID, were worse for those with vulnerabilities. Almost any vulnerability had a distribution like this. Here we're looking at the socioeconomic gradients that existed in the countries that we had information on in the time we published the report. And you can see that the mortality doubled in many. Now, I want to emphasize a couple of points that while increasing prevention and primary care is an important technical and allocative efficiency issue for a high-performing health systems, The reason that we're advocating it for its resilience aiding policy is that because disruption in services is incredibly problematic for those with severe multimorbidity. Societies with less prevention and more treatable morbidity will find absorbing a crisis harder, and the recovery slower because the demand for healthcare will increase even more during those times of crisis. And the consequences of delaying and deferring care, as we saw in the pandemic, will also increase. And you can see that a potential feedback loop develops. And again, I was mentioning feedback loops are important, thinking about the dynamics are important. And so here, what happens is that the feedback loop starts with increasing diverting treatment effort to treatment, and that reduces prevention further down the track, which again worsens population health, which again leads to greater treatment requirements. And so therefore, a shock leads to greater disruption and slower recovery in systems that do not preference primary care. The second recommendation is around the workforce. And this slide demonstrates a really simple association between a larger workforce, and here, because of the pandemic, we counted the workforce as not only those in healthcare, but those in social care because of the enormous impact on social care, and reduced excess mortality in 2020, 2021. Now, we've just finished redoing these figures for 2022 as well, and the association continues. This simple association, that increased workforce is correlated with decreased excess mortalities, continues to hold up when you start adjusting for other factors such as GDP per capita and the size, the portion of the population over 65, both that we've done and most but not all academic pieces. Now, the workforce really demonstrates the importance of considering all the stages of the disruption cycle. It's not simply that enough workers exist to absorb a shock. You need to make sure that if the shock is sufficiently long and of sufficient intensity, like the pandemic was, that increased effort as a solution is not the response that you take for a prolonged period of time. Increased effort as a solution burns out workers and essentially makes the recovery for the system harder. And you can see that in some countries now. A workforce is a key issue for resilience is also highlighted by the fact that as we look over the pandemic, progressively most of the other issues were solved, but the workforce one remained almost all the way through the pandemic. Infectious diseases are notorious for putting a workforce at risk, and protection, both physical, mental, social, and financial, is required. However, for those of you who've got a clinical or disaster background, you know that most large shocks will have an impact on workforce availability. Earthquakes, fires, floods, they all disrupt the ability of the workforce to get where it's needed. Now, we've estimated that we need about 3 million extra health and social care workers across the OECD to bring the resilience of those countries that didn't seem to have a sufficient workforce up. And I think this is the recommendation for this audience that you might want to take the most umbrage with, that when you look at the numbers we've suggested across the OECD for the world, we're beginning to talk the multiples of tens of millions of extra healthcare workers are required. And of course, one of the issues we touch on the report, but is of incredible interest to those who look at worldwide resilience as opposed to resilience of OECD countries, is where these extra workers are going to come from. If they're not come from extra training, if they come from the migration of workers from other countries, we're not simply improving the resilience of the healthcare of some countries. What we're doing is trading the resilience of some countries for other countries. And that's something I think we should all be aware of. Now, continuing the theme of workforce is the requirement over a disruption cycle for staff to fulfill different roles and respond to different challenges. Because there's a range of different threats and a range of different recoveries, agility of the workforce is paramount when you start thinking about resilience. And we saw this during the stage of absorbing the pandemic, with widespread role changes in what services were provided and who provided them and where they were provided. This slide shows the wide variety of additional roles taken on by non-physician healthcare workers during the pandemic. A number of roles that were considered not to be appropriate for non-physician workers prior to the pandemic in some countries, and not to mention the enormous increase in telehealth across OECD countries. Now, these changes and role changes to accommodate and absorb need to be planned before things happen, but they also need to be accompanied and supported by financial, organizational, and governance structures that reinforce them. Basically, as we move on to the recovery stage, a different set of skills will be required by the workforce. Being unable to have sufficient staff will make this process more laborious, and not having agility in the workforce makes it more difficult. So not being able to absorb quickly and not having greater staff, as we've discussed, results in greater disruption. And this slide shows a reduction across the OECD countries of hip replacements in 2020 as a percentage of the activity in 2019. And as you can see, some countries, including the one that most of the audience are in, faced a larger burden of deferred care and haven't caught up on it, whereas other countries didn't. Of course, there's another concern of a feedback loop here, that increasing harm and effort required by the workforce reduces the workforce, resulting in a greater burden on those who remain, who means more people leave the workforce, resulting in a greater burden on those who remain. Now, one way I think of it, it may not be very useful, is the workforce is your ability to do things. And as we've highlighted, the workforce is the key to responding to challenges. You need to know what it is that you need to do. Data and information are vital to understanding what to respond to and to support organizational changes, especially when you start engaging in large-scale changes. Identify unintended consequence and promote decision-making based on evidence. Again, a key issue here is not simply that we need greater data availability more readily, which we do. We also need the ability to quickly develop and integrate new data sources as required. And we saw that during COVID. For example, COVID cases, testing, wastewater were all required to try and understand what was going on. At the beginning of the pandemic, only 4 OECD countries had effective real-time data available to decision makers. There are more now, but it's still not everyone. And this slide shows the policies implemented in the OECD countries to manage the critical care surge. What is really striking here is the number of policies that rely on high quality data for decision-making and changes in organizational structure. Data underlies the use of your resources effectively. And as we progress through the pandemic, we need different sorts of data. Data on vaccination, data on miscare, data on mental health, data on long COVID, data on well-being, data on the educational impacts. High quality data and the ability to integrate multiple areas of high quality data identifies those who need help and allows us to respond to weaknesses quickly. Beyond that, a mature data system helps in absorbing and recovering from a disruption. Data that follows the patient mitigates the harms of the transitions that occur with disruptions. And we saw that. Organizations that could quickly move the data around to follow the patients were able to change the place at which the patient received care with minimal harm. Those that could not, could not. Telehealth, which was a major way of dealing with some of these issues, is easier to implement, and care between crises can become more integrated and effective when you've got better data systems. So moving on to the other non-health recommendations is talking about the interconnections between countries and the benefits of acting cooperatively and the dangers of not doing so. And so some actions just have a lower cost and a greater benefit if they're taken collectively. And we all know about these, and those with the economic background, the externalities that exist. And infectious diseases surveillance is the classic for this. Reducing the spread of infectious diseases benefits all. But another example is investment. Many of the products and technologies that we need during a crisis have a really weak business case between the crisis. And COVID vaccinations were a good example of that. There was the potential to do them, but there wasn't the business case for people to produce them. We've seen it's possible to actually create them in a very short period of time with staggeringly large investment. But as the slide shows, the results were inequitable. So what we need to do is we need to make it more possible to research, develop, and distribute essential technologies for absorbing and recovering from crisis in an efficient and fast and equitable way. But the benefits of international cooperation are potentially much larger than that. The sharing of staff and resources, and even the movement of patients to lower the burden on individual areas occurred during the pandemic. The ability to combine information and share it rapidly around systems improves the speed of responses and the evidence base upon which decisions are made. For example, the use and sharing of COVID-related data allowed safe travel during the pandemic, and international trials were launched. A key issue that I think that comes from this, and will occur again, is the lack of certainty about the right policy options. For example, we still don't know precisely which containment and mitigation measures work well, and which suite of measures would be the best ones to use in the unfortunate event of a future pandemic. The greater ability to link data internationally and learn from one country to another, the faster and the better we'll be able to manage these in the future. The other issue is scarce resources. That planning on an international or regional basis, rather than simply a country or sub-country basis, allows a degree of efficiency in, for example, the stockpiling of essential medicines and medical devices, and reduces the cost for each individual country and potentially improves the benefit. But it really needs to be accompanied by credible mechanisms for when widespread shortages took place. Without those credible mechanisms, versions of the feedback loop of hoarding will occur. So where a fear of a shortage creates the shortage as each country attempts to gain its own store. And we saw that again during the pandemic. During the pandemic, there were interruptions as countries enacted international trade barriers and tried to keep things for themselves when they may or may not have had better uses elsewhere in the world. Which brings us to the fifth recommendation, supply chain resilience. So shortages in medicines and medical devices aren't new. For those of us who have been working clinically, there's 200 or 300 a year in just about every country. But the acute shortages at the beginning of the pandemic were absolutely devastating. This slide shows the characterization by OECD countries of the shortages in devices and medicines used in the absorbed stage of the COVID-19 disruptive. And I don't think it'll be news to anyone that PPE, personal protective equipment, ventilators, and testing equipment were the things that people found the hardest to get hold of. And basically this underlay another set of feedback loops where increasing infections and border closures interrupted supply chains, which reduced the availability even further. Most countries diversified suppliers and engaged in local or near local production. And over time, that production increased and demand fell. And so there is a solution, increased production. But the problem is how to reduce the impact and the time of acute shortages. And so basically we're suggesting three main things here. So first is a greater level of information to anticipate, diagnose, and implement effective policy choices in supply chain resilience. Secondly, that procurement strategies be guided by that information so that essentially resilience is built into the prices and the requirements that you make of suppliers. So one of the issues is that trying to look for low cost, which may be more efficient, may predispose to choosing suppliers which have less resilient supply chains. And thirdly, we consider stockpiling strategies so the aim is achieved. And it's important to think about how all these things are going to interact together. And as I said, it's a really key point to think about how your stockpiling strategy is actually going to work in a time when there is a global shortage of whatever the good that you're thinking about. So on to the last of the six. So basically, I don't think it's a surprise to anyone, but trust and governance beyond the health system is absolutely essential. As we saw in COVID, and we'll see again, any sufficiently large shock requires a whole of society approach under conditions of extreme uncertainty. So here we've shown the simple association between COVID-19 vaccination and excess mortality across OECD countries in 2021. And increased success in vaccination is associated with decreased excess mortality. Without governance mechanisms beyond health, effective policies cannot be introduced, and without trust, policies may not be adhered to. As we saw, and this is a really key issue during the pandemic, policies will change as the evidence changes. That the decisions that were made initially may need to be revisited as greater evidence is gained, and the population needs to be taken along with this journey, that it is not useful to insist that you've made the right choices and will not deviate at the very beginning of things. So this should be anticipated for and planned for. And that means that you need to think about countering the mis and disinformation that accelerates in situations where it appears that choices have had to alter. And so mis and disinformation, we can see using the OECD data, has increased across many countries, and proactively dealing with these issues is absolutely important. So I've kind of done a very quick tour of the big ticket items of what we need to increase, what we need to do to increase resilience. But I want to return to the issue about the potential trade-offs between resilience and resilience and efficiency. And that is a resilient system the most efficient system? And basically, there's a lot of debate around this point, with some resilience experts arguing that very highly efficient systems are probably not resilient, and that a degree of efficiency should be sacrificed to ensure that systems can withstand shocks and not fail. And essentially what we're talking about here is we're talking about a degree of redundancy in the system so that you can absorb when something happens, and also the idea that you put in place mechanisms and governance structures that can be activated, which all occur at a cost. And so if you recognize that there's these trade-offs, you start thinking about what's the right way to start implementing a program of work which increases efficiency and preserves as much health system performance and resilience as you can. And so we've tried to cost the suggestions of our 6 recommendations, really focusing on the first 3, because that's where we're more expert on. We haven't tried to assess the cost of trying to increase trust. And our estimates are, for those policy areas, we're looking at health systems across the OECD having to spend an extra 1.4% of GDP on health relative to the 2019 expenditure. Now, in 2020, most health systems actually increased, most OECD health systems increased their expenditure by that amount, but we can already see that in 2021 and 2022 that they're beginning to decrease the expenditure relative to this. And we can see that most health systems have increased their expenditure on prevention, workforce, and the digital foundations of health. Now, on to this really vexed question about whether there's a trade-off in performance, efficiency, and resilience. And I think some of the things that we're suggesting will actually improve both. Better data and greater prevention will improve performance and efficiency as well as resilience. However, for those things where there's a degree of redundancy required, there may be a trade-off, especially if you're measuring efficiency in the short term. And that's something that we need to think about very carefully. However, if you don't think about resilience, health systems and societies will be vulnerable. And then when something does happen and you have a large shock, you will involve yourself in large, costly, less effective interventions and more harm as a result. And so therefore, it's one of these things that we have to think about is we have to think about, and this is our primary recommendation about how to think about these things, is you've got to think about it over a longer time period. That a 3 to 4 year budgetary cycle probably isn't enough to be thinking about these issues. You need to be thinking about it over the time frame where you think it's plausible that you will experience shock, so 10, 15, 20 years. The other thing, and this is a lot of George's work as well, is that there's enormous challenges in implementation. There's a lack of consensus about exactly what resilience is. I've given you one pitch, but if you read another book or look at another academic article, you'll get a slightly different pitch. There's lots in common, but there are some subtle differences that actually make it difficult to be sure we're entirely talking about the same thing all the time. And one of the big ones is around risk and uncertainty. So the pitch that I've made here is around risk and uncertainty, that the issue is that you need to prepare for shocks you can't even describe, the unknown unknowns, as opposed to making a list of the risks that you think you face and trying to counter each of the ones individually. The other thing is that there's a lack of prospectively validated indicators for resilience at the moment. And a lot of the work that George and his group are doing is trying to cover this gap, that essentially what we're interested in resilience is we're not interested in how the system is going right at the moment. We're interested in predicting the performance under pressure that we're not observing at the moment. And that's a more difficult task. And we also have difficulty with a lot of the information about metrics of resilience we are missing. For example, metrics around cooperation and governance are very difficult to measure. And then, as I've tried to emphasize over and over again, a lot of this is really about thinking about systems. So the health system in connection with a number of systems that are important to for the health system to work properly, and the possibility of feedback loops over time. And so this brings you to the question of what systems, which systems should we be including, which systems should we be thinking about the feedback loops. And as I've already said to you, even in this report with 3 months, we're already thinking that we missed the education system. And then another key aspect is we often have a lot of information before things happen. We tend to have less information during things happen and after them, because it's a bit more difficult to measure and people have other priorities. I do want to touch upon how some other people have attempted and looked at trying to solve some of these issues. So this is the moderator's work. The LSE is in the Partnership for Health System Sustainability and Resilience. And I actually think for some of the issues that I said the OECD report is a little bit weak on, these are really good to look at. So basically the focus is on individual countries, and it includes a wider variety than we've got at the OECD. For example, Vietnam, India, and Egypt. And they also include both resilience and sustainability simultaneously. And I think that's a nice way of looking at some of these things, as opposed to what we did, which was look at resilience essentially in isolation and then talk about what it meant for other issues. Having said that, most people tend to end up at the same place, which is suggesting that multiple issues need to be tackled simultaneously. And I quite like the environmental sustainability that's been included in this work. And then another report that I'd like to commend to you, if you've got time to read them, is the World Bank one. And I'm going to use this to just put some reflections that people may want to pick up in the chat. So both the report that we wrote and the World Bank report had a similar framework in that we both looked at health systems and some of the issues a bit further than health systems. And there's a lot of similarities between them. But I think it's really interesting to look at the differences. And I don't think these can be underestimated as a result of the membership of the OECD versus the membership of the World Bank. The biggest difference in my mind is community health workers, which for the World Bank report are at the absolute center of it. And I think that's a real strength of their work. The other thing I'd like to just start with as a kind of entree to questions is about what we found difficult and what we found not so difficult. And to be honest, it was more difficult than not difficult. And so, as I've said and I've hinted, systems thinking is really difficult to motivate on the page. That it's easier to do if you're talking to people and you can kind of take them through it, but when you write it down, it's actually really hard to make it convincing. And we went through, I think, 6 iterations where each one we reduced the technicality of the systems thinking in the report. And when I look across the literature, I think other people made similar decisions. And I think the ease of readability of these reports and the ease of digestibility really means that you leave behind some of the real difficulties about thinking across multiple systems. Then a couple of things that I think we're all grappling with going into the future, which is how distinct to make the assessment of health system performance and resilience from each other. And essentially, you can put them side by side. You can make them resilience as part of your health system performance appraisal. So almost make them almost identical, or sorry, considered in the same framework. One of the difficulties with that is that resilience keeps popping up in different places. So it doesn't just pop up in health system performance, it also pops up in your responses to disaster, and it pops up in international organization. So one of the real questions is, what's the right frame to be thinking about these issues? And the simple answer is you need to be thinking about it at multiple frames. So whether we think it as a health system issue, whether we think of it as an international issue, whether we think of it as a disaster issue, whether we think of it as a pandemic preparedness issue. And then going back to what I was saying, we're all characterizing resilience in slightly different ways. So as a piece of critical infrastructure, part of a pandemic response, part of a community response, as a property of the health system. And does it matter that different organizations are going about it in slightly different ways? I don't think it does, because I think that we're trying to solve different problems, and solving different problems means applying the tools in a different way. But I do appreciate that that makes the coherence of what's going on a little bit more difficult to appreciate. Anyway, I might stop there because I promised that I'd go no more than 30 minutes, and I think I've hit that. But I'd love to hear your questions and your observations. Thank you very much. Back to you, George.
Fantastic. Thank you so much, Phil, and genuinely illuminating. I've been grappling with, as you noted, some very similar issues, but I think that you communicated it so precisely and so straightforwardly, and frankly, in a way that in that overarching report for PHSSR, we really struggled to do. So I'm glad you also noted the challenges of communicating around resilience. So yes, let's open it up to the floor. We invite questions from all the participants. Feel free to unmute yourself and ideally put your camera on and ask your question directly, or put it in the chat. Hugo, I can see you got your hand up. Why don't you start?
Hey, hello. Thank you very much, Dr. Phillips, Professor George, and for being with us today. I was thinking with this presentation that, of course, resilience is quite a complex topic, of course, and that's precisely the nature and the purpose and what can be gained from that. My question then becomes, because you mentioned, well, low middle income countries and high income countries have huge differences, and those differences make it hard to have a global perspective and a strategy on how precisely to come with preparedness to these shocks, that some of them, as we saw in the past, are global, though others are regional. And so my issue also, as you mentioned, the difficulty to understand some issues in healthcare comparing to other sectors is the issue on gaining the confidence and the commitment, for example, politically in those countries, coming from the fact that they understand partially what are the issues and how to solve them. And so they don't have, as you said, the trust of confidence to invest on those, and also the other organizations that are trying to come from outside. Thank you very much.
Yeah, thanks for that. There's a lot there to unpack. So I mean, it's a great question, but I might kind of do it in three bits. So the first one is thinking about international resilience, and I think you can think about this in three different ways, just essentially depending on where you assess the benefits. And so on a very hard-nosed level, you could assess international resilience on the benefits to each country. That is, as you all know, that there's a benefit to countries of problems not starting in other countries and then spreading to them. Now, one of the issues is that the world has got far more interconnected than it ever was. So so what we think about is the transmission of shocks. So how quickly a shock spreads geographically is much, much faster than it used to be. So if we go back 50, 100 years, the spread of disease, because the spread of travel was so much less, but the spread of say technological threats, so cyber attacks and things like that, much easier now. So there's a interest in every country in protecting itself from that, and it may be more efficient to do that in a way that's associated with sorry, that was just someone popping in to offer me a cup of coffee. It may be easier to do that where the threats originate. Okay, so that's the most simple one, but that I don't think gets you to a level of investment that we're beginning to talk about. So the second ones essentially start moving around the idea of equity. So the idea that that there may be trade-offs in resilience by moving resources from one country to another, where the benefits to the country you're moving it to outweigh the losses that are experienced in the country that you're moving it from. And that, I think, is where we need to start thinking about. So I think the first one doesn't get you to a solution for all threats. I think it gets you to a solution for some specific threats. The second one, I think, gets you to a solution to a greater level of threats. And then the third one, which I don't believe is possible, but some people will argue, which is that you start off from a kind of position of a world, taking it from a decision maker that's looking at the world and how they would allocate the resources. So I don't think we'll achieve that one, because I don't think it's possible to get in a compelling set of contracts for it. So that's where I go on the world one. With the trust one, yeah, I think we are limited at the moment because. And when I say we, I mean us and the resilience steer, because I don't think right at the moment we can give people a completely accurate description of the benefits of resilience and the costs of resilience. That essentially the problem that we've got right now is that we need to convince people in the middle of a cost of living crisis that it's worth these investments. And people look at the very short term and say, in the short term, I have these problems. And what we need to do is we need to convince people with evidence that the benefits of investing now are worth it over the long term. But that means having a conceptualization of resilience that actually allows us to calculate the benefits in a way that's amenable to understanding by politicians and people. And then, as I say, that needs to be combined with thinking about these outside much longer than an electoral cycle. If we keep getting stuck in a 3 to 4 year cycle about how we prepare for resilience and resilience investment, we will not make our systems resilient. And I might stop there.
Great, thanks, Philip. And yeah, I couldn't agree with you more on that point. A lot of what you've spoken about has brought to mind, you know, how we've used the concept of sustainability within the PHSSR work, and now isn't the time. Maybe we'll do a separate lecture on that work for the students, but this is your time. So we have another question from Henry F. And that question is, if you were to recommend one policy area of the 6 you outlined, or even a specific policy within one of the 6 areas to improve health system resilience, what would you personally recommend, considering both the anticipated impact and feasibility of implementation? Yes, yeah. Apologies for not being able to turn on my microphone at the moment.
Yeah, no, yeah, and again, great question, because this is what it all comes down to. I mean, I mean, it'd be lovely if people would implement all 6 and they're mutually reinforcing, but people will choose to implement 1 or 2. So I'll answer this with all my biases, and that's I mean, when I look at the problem always stems from a lack of information. So the ability, people within the system don't know what the best thing to do is. And so I mean, I would, if you were only allowed me one, and it's feasible, I would start with data. And I would start with data getting to where it's needed for the people who need it. And the reason I say that is twofold. The first is I think it's feasible. In that I think it's feasible for multiple countries as well. And the second is that I think it will allow a virtuous circle of people then beginning to fill in the gaps. Now, having said that, I feel very torn, because I think the biggest problem today, like right at the moment, is workforce. Like, I think overwhelmingly the biggest problem today is the potential for a vicious cycle around workforce. And so if you said today, fix fix resilience, I would say workforce. If you said abstract a little bit away from today, what would be the thing that you think would improve? It would be data. But it's a great question. I think the workforce one is actually a harder fix than data because of the lead times that are required to build up the workforce, and so therefore I think it's one that's going to be a little bit more tricky to solve in the medium term, especially at a worldwide level.
Great, thank you. And again, very much agree, and it does accord with some of the recommendations in the PHSSR reports. And I think when asked, Professor Maguire, who's led the PHSSR work, focuses very much on workforce as a key area. But perhaps a step further abstract, that question about planning cycles and the lack of a long-term perspective, being really at the root of the lack of preparedness, a focus on short-term efficiency gains at the expense of resilience, whereas if you take a longer-term perspective, a resilient system is an efficient system. It requires politicians and budgetary cycles to be, politicians to think about planning horizons in a different way. So that's what I would vouch for. Right, do we have any further questions? Okay, Hugo, go ahead.
Well, thank you. Meanwhile, we get some other ideas. Let me ask you, taking one example to make it more practical. For example, antimicrobial resistance crisis that we consider and we know for a while already. We know that it will get soon, and the impact will be huge. And precisely as you say, the focus needs to be in several systems in the long term. And so precisely here we start considering not maybe only the fact or clinically to get new antibiotics, but precisely the education to prevent a huger impact in the future. Well, just as an example. Thank you.
Yeah, no, a great question and great example, because I mean, there's lots of things you can think about, and as I said, you've got to prepare for unknown unknowns. But the two threats that we keep cycling around are antimicrobial resistance and climate change, and they're very distinct from each other, but they share a number of common features. So the first is that the prevention and mitigation strategies are multi-sectorial by their nature. And actually the prevention and mitigation strategies, more for climate change than for AMR, but also for AMR with the amount of animal husbandry inclusion, actually a lot of it lies outside the health system. And so that's where we need to start. Now, AMR was part of the reason that we put in the investment discussion. It wasn't really around COVID vaccines, although that's what we spent a lot of time talking about. We really wanted to look at the failures in the market related to the production of new antibiotics, which are immense, because one of the issues is that in order to make a system of investment work normally, you want to use and sell a lot of whatever you're building or investing in. So, but with AMR, we want to do the exact opposite. We want to develop antibiotics, but then we don't want to use them as much as they could be used, which means that we need to think about A, incentivizing the production, but B, disincentivizing the use. And that's actually quite a complicated area to work your way through, because you need to intervene at multiple levels in the system. The other issue with AMR is that you can think about that side of things, essentially the supply side towards AMR, but you can also think of the complications that occur once AMR may exist. And so from that point of view, it's worthwhile thinking about those things that you'd need to do if there was widespread antimicrobial resistance to a degree further than we've currently got. And we've tried thinking about that from the resilience point of view as well. And essentially, you end up thinking very carefully about the degree of universal health coverage and how you can actually stop these outbreaks of antimicrobial resistance in a way where everyone is incentivized to do what is required to do that. And that means making sure that you've got a flexible universal health coverage approach so that as things occur, you can rapidly get on top of them, taking into account the externalities. So that was a bit of a tiki tour because that was a bit of a tour of it because it's quite a complicated area, and as you say, you need to make sure that you get all the systems lined up. But essentially, you need to start thinking about mitigation, but not just mitigation. You also need to think about what's going to happen when you're going to have a crisis. And the same thing occurs with climate change. Yes, you need to incentivize all the mitigation, but to a certain extent, we also need to think about how we're going to deal with heat wave crisis, infectious crises associated with them. And a lot of the climate change work, you begin to think about a lot of the burden of that's actually not going to fall on the health system itself. It's going to fall near the health system and require a lot of effort, essentially from the community to be involved. And the sooner we start thinking about how we're going to deal with that and training the community to help us deal with that, I think the better off we'll be. Thanks, Hugo.
Fantastic. Thanks, Philip. And so, Philip, while we wait for another question from the students, we have another 5 minutes or so. I've got a question for you. So you mentioned 1.4% of GDP additional to existing health expenditure to implement the recommendations that you're making in OECD countries.
Yeah.
I have 2 questions. So the first one is, I'd be really interested in how you develop that estimate. I know that the OECD has a wealth of data to draw on, but how did you develop that estimate in highly simplified terms for me, please? Secondly, what would it take to produce such a figure for countries in the global south or lower middle income countries, given the data challenges, given the much lower baseline health expenditure, sub 5% in many cases? And I mean, clearly it's going to be a very, very big number, not least because the majority of the world's population is living in such countries. So 2 questions. How do you do it? And secondly, how could it be done for the rest of the world?
Yeah, thanks, George. Great questions. And I mean, I think the basic answer to the second question is I'm not sure it would be affordable the way we calculated it for OECD countries. So I think we'd have to come up with something else. So basically we looked at 3 components. So we looked at staffing, we looked at information technology and capital expenditure, and that we looked at prevention. And for each of them, what we did is we established a baseline that we thought all countries should move to. And so here we established the baseline based on OECD countries, and pretty much it's taking some of that information that we presented about the associations and trying to unpick that slightly. And so we started off by suggesting everyone below the mean move to the mean, and calculating that. And then we realized that once we actually started looking at the data, and so here we've got to have data on workforce, we've got to have data on wages, we've got to have data on investment, and we've got to have a health system accounts that's sufficiently disaggregated enough and accurate enough that we can start thinking about these things. We decided both the mean and the median would probably be too low, looking at actually what happened during COVID. So then we moved up to the 70th percentile. And that's what would make it completely unaffordable for low and middle income countries if you said they should all move up to the 70th percentile, especially for workforce. And then we also increased wages for those countries that were below the mean, up to the mean. And our thinking was we needed more workers, and we would need to pay the workers more. So that's how we calculated it. And then basically there are some countries for which they don't need to, the changes are quite small because they've already got large workforces, they've already got large investments in infrastructure, and they've already got relatively large investments in preventative programs. But we were sufficiently lacking in confidence to start putting each of these numbers out for an individual country. So we just went for an average. Now, if you kind of look at the 75th 25th percentiles when you do that. It's kind of, forgive me if I get it wrong, 0.7 to 2.1 was the range, and almost half of it, almost half in almost all the scenarios we did was the workforce. So, and in some of them it got up to 2/3. So the spending that we're really talking is about workforce spending. And so I know you guys did something very similar as well. And so I think there's a lot of complementarities between them. But in terms of data, yeah, we need to have data on how many people are in the workforce, how much they're paid. We need to be able to establish a baseline that we should move to, which is what we use the COVID information for. And then we need to have information on how much is spent in prevention and how much is spent in infrastructure. And before this meeting, I just did a bit back of the envelope calculation, came up with some completely unreasonable numbers for low middle income countries if we were trying to do this.
Okay, fantastic. Thank you very much, Philip. That's a brilliant answer to my question, and I'd like to follow up with you because I've got some further questions for you. Unless you want to share your figures.
Yeah. I've got to say we're happy to share the figures, and we're happy to share how they're calculated. Well, as I say, what we don't like to do is say the US should spend X in Norway, because we're not sufficiently confident that we've got all the subtleties in using some broad brush averages. So that's the way we try and say it.
Very wise, very wise. Okay, well, we're up to time. A huge thank you, firstly, to Philip. Fascinating talk. You've answered the questions really fulsomely as well, and yeah, great to have you with us. So thank you very, very much. Thanks as well to Hugo and the Health Society for organising this. Great job, great choice of speaker. Well done. And again, thank you very much, everyone.
Bye-bye.